I'm curious, this is the interactive stretch part. How many of you take care of adult sickle cell patients on a regular basis? All right, so it looks like about half of you. And of those that raised their hands, you feel fairly comfortable in taking care of them? A little bit? Okay. All right. And then for those of you who don't, this is one of those things where you have to read about it just in case one happens to walk into your emergency department. I've been taking care of sickle cell patients now I was thinking about it since a medical student. I've been taking care of sickle cell patients for 35 years. I work at Jefferson Hospital in Philadelphia. We're a regional sickle cell center. I've seen many sickle cell patients over the years. I'm actually part of the sickle cell team that takes care of our cohort of patients. So I just want to tell you, what I want to do today is tell you, what do you need to look out for and how do you treat these patients? Right? So sickle cell crisis, is it something more? Right? Here's one of the easiest pathophysiology lectures you will ever have. All right? This summarizes above, which is normal, red blood cells that flow through the vasculature very easily. Down below is sickle cells. So think of it. Sickled cells don't flow through. They aggregate. They adhere. They essentially cause tissue ischemia. And what happens is, over the course of a patient's lifetime, that ischemia causes tissue damage. And it's a unique disease. Low level of ischemia interspersed with sometimes many episodes of acute ischemia, and that's what we see. All right, I want to focus on adult. I think if I had to talk about pediatric sickle cell, that's 2 Pecha Kucha lectures with all the things that goes on there. I will suffice it to say, if you see a child that has sickle cell disease, if that child comes into your emergency department, you're looking to find the reason why you're admitting that patient or getting them into the hospital, because there's a really good chance that they have one of the serious complications of disease. So I want to focus on adults. This is what you see. So for all of you who raised your hands and said you see them on a fairly regular basis, when you're looking at adults, this is what you see. They come in saying, I have my sickle cell pain. It can be infrequent, can happen once every couple years. It can be very frequent. Some of our patients come to our emergency department. They'll come weekly and sometimes even more. But that's what we see is vaso-occlusive crisis, pain. It's that acute ischemia that we're seeing that brings them to the emergency department. All right, so that's what you see. That's probably 99% of what you will see. We'll talk a little bit about how you take care of that pain. There are 2 conditions that you need to be looking out for. So when I'm seeing a sickle cell patient that I know very well, I've seen them many times, the questions that I'm asking are not so much aimed at their pain, but really it's looking for 2 particular conditions. So I'm curious, anybody ever see acute chest syndrome in the emergency department? In the emergency department? That's pretty good. That's actually, you're one. So we looked at how many raised their hands and then how few of you raised your hands seeing ACS. Well, it's not a particularly common condition, yet it's probably the one condition that will kill an adult sickle cell patient. This is what it is. So when you look at the criteria that I have up here, this is how we diagnose it. Well, that looks like pneumonia, hypoxia, chest pain, fever, new infiltrates. How do you know that it's not pneumonia? Well, you really don't know that it's not pneumonia. It might be pneumonia, it might be ACS, it might be both of them combined. Suffice it to say that pneumonia can cause ACS. Half of sickle cell patients will have ACS at one time in their lives. Unfortunately, most of them happen, well, I say unfortunately, depends on how you look at it, most will happen in the young age group, ages 2 to 4. But we do see them in adult patients. So when I asked you how many actually saw it in the emergency department, I can't remember the last time I saw one at our center in the emergency department. Most of our patients actually develop ACS while they're in the hospital, because it tends to occur 2, 3, 4 days after the onset of their painful condition. So when you're asking the patient, how long have you had this? Are you having chest pain? Are you short of breath? Consider that 2 to 4 day kind of lead time with their painful crisis. The other condition, infection. So when I'm talking to a patient, I'm asking them in so many words, are you infected somewhere? Because that is the other condition that will cause problems for sickle cell patients. Adults are essentially asplenic. They can't fight off infection, especially to encapsulated organisms. So look for infection. This is particularly important in a kid. If you see a kid, they're probably infected. These are some of the other complications. They're really not very common at all, but things that you need to worry about. Hepatic syndromes, sequestration crisis, stroke. If you ever see priapism in the emergency department, at least at our place, it's almost always a sickle cell patient. All right, how do you take care of the uncomplicated? So that's what you're looking for. How do you take care of the patient that comes in saying, I have pain, I have my sickle cell pain, I don't have anything else? Many of you, those of you you get CBC, reticulocyte count fairly regularly. If you're not really familiar with the patient, you should get a CBC and a reticulocyte count. 6 to 9, that's usually what we see is a hemoglobin level of 6 to 9. If they're lower than that, they're going to have worse tissue hypoxia. This is the reticulocyte count. We normally see them above 5 in a sickle cell patient. So when it's below, you got to worry about that they're not producing enough red blood cells. Don't use oxygen for acute vaso-occlusive crisis. It doesn't work. It doesn't do anything. Use it if they're hypoxic, if they have a reason to be hypoxic. Don't give fluids regularly. Again, there's no reason to do it unless they're dehydrated, just like you might do with any other patient. There is no evidence for it. Analgesia, what I'll simply say is be aggressive. Now, it's not all that easy to do in this day and age of opiate abuse, but the evidence shows that high dose, frequent, aggressive treatment is the way you want to go. There's no set amount for every particular patient. It's usually individualized. Just make sure that you give enough. When do you transfuse? When they're anemic. Usually when they're below 6, we transfuse. If you're worried about volume overload, we do exchange transfusion. We get rid of the sickled red cells, give normal red cells. We typically do this with acute chest syndrome, with stroke and multi-organ failure. Those of you who take care of sickle cell patients, you know exactly what I mean by this slide up here. Some of them, a subset can be some of the most difficult patients that you'll ever take care of. Just the one point I want to make out of that subset, that group has the highest mortality of adult sickle cell patients. All right, so just to end, I'll just say, make sure you care about these patients. It's a difficult disease. They inherited this disease. Take care of them. Try to believe them as much as you can. Look very carefully for these complications, especially in kids. Kids, get them admitted to the hospital. Pain medication, make sure that you give enough. Thanks. Any questions?